Hi, everyone. Thank you so much for joining us today for CPHA's Beyond Stigma webinar. We'll begin today with some introductions. So we invite you to use the chat function on Zoom to introduce yourself. You can share your pronouns, the organization that you're working with, and we invite you to acknowledge the land that you're joining us from today. I'll begin. My name is Kelsey, and I'll be moderating today's webinar. My pronouns are she and her, and I'm a project officer for CPHA's Substance Use Project. And today I'm joining you from the unceded and unsurrendered Algonquin Anishinaabe territory known as Ottawa. So please feel free to continue adding your introductions into the chat, and I'll go over a little bit of housekeeping. So all participants are muted, but we're hoping to engage you throughout the webinar using some other features. If you have any general comments, please post those in the chat box in the toolbar at the bottom of your screen, and these comments will be visible to all participants on the call today. If you have any questions for our panelists, please post those in the Q&A box. While we encourage inquiry and discussion on this topic, it's important to note that we do not invite criticism of the lived and professional expertise of our presenters. The format for this webinar will involve a viewing of the Beyond Stigma video, followed by a panel discussion, and finally a question and answer session at the end of the webinar. If you think of any questions during the panel discussion, please drop those in the Q&A box, and we'll try to get to as many as we can in the later portion of the webinar. This webinar is being recorded, and the recording will be made available on the Canadian Substance Use Resource and Knowledge Exchange Centre, SURE, at substanceuse.ca and on CPHA's YouTube channel. Once again, we want to thank you for joining us today for this webinar titled Beyond Stigma, which is being hosted by the Canadian Public Health Association as part of our Normalizing Conversations project. In 2022, the Subject Matter Health Research Lab published the animated Beyond Stigma video, which we will watch shortly. This video was created to explore the impact of stigma on all aspects of treatment for people living with opioid use disorder. It was created in collaboration with academics, clinicians, and people with lived experience, and has been endorsed and disseminated widely to both national and international audiences. We would like to note that the use of the term opioid use disorder in the Beyond Stigma video is context specific. It's important to acknowledge that the majority of people who use substances do not have a substance use disorder. For more information on this distinction, please refer to the resource Communicating About Substance Use in Compassionate, Safe, and Non-Stigmatizing Ways from the Public Health Agency of Canada. Now I'll introduce our panelists who are each involved in the development of this video. Dr. Kirsten Dixon graduated from the School of Medicine at Queen's University in 2006 and completed her residency in family medicine through St. Michael's Hospital at the University of Toronto. Dr. Dixon's clinical work is focused on the care of people experiencing homelessness, mental illness, and substance use disorders. She works with a shelter-based outreach team through the Center for Addiction and Mental Health and was the lead physician with Inner City Health Associates for Seton House Men's Shelter from 2017 to 2020. Since 2015, Dr. Dixon has worked with the Safer Opioid Prescribing Program at the University of Toronto on course development and facilitation. She is dedicated to enhancing education on opioid use disorder and to improving the quality of care delivered to people who use opioids. Sean LeBlanc left an abusive home situation in the Maritimes at age 13 and eventually put himself into university, where the loss of his pregnant partner started a decade-long run of addiction and homelessness. Sick and tired of being sick and tired, he used his stubbornness and desire for positive change to eventually found a nonprofit to advocate for drug users in Ottawa called DUAL, the Drug User Advocacy League, in 2010. He spent years as a frontline worker at Ottawa Inner City Health and is now a research assistant and consultant with Mount Sinai, St. Mike's, and a proud CAPUD, Canadian Association of People Who Use Drugs, and ONPUD, Ontario Network of People Who Use Drugs, board member. He's a huge Red Sox fan and loves punk rock, harm reduction, bass guitar, and his partner, Catherine. Next, we have Kristen Ellis McDonald. Kristen is a family nurse practitioner in the First Nations community of Wagmatcook, located in Cape Breton, Nova Scotia, where she has practiced for 3 years. Prior to this role, Kristen greatly enjoyed working as an NP in a rural community located in northern British Columbia, where a large part of her patients were of First Nations ancestry. Prior to her career as an NP, she worked as a registered nurse and specialized in vascular, general surgical, neurosurgical, and critical care ICU in Halifax, Nova Scotia. After being away from home for so long, she's happy to be back working where she was raised in Cape Breton and grateful to give back to the surrounding communities. And finally, we have Dr. Abby Manu-Sud. Abby Manu is a family physician based in Toronto, Ontario. He's an assistant professor at the Temerty Faculty of Medicine, University of Toronto, and research chair of primary care and population health systems at Humber River Hospital. His clinical research, education, and advocacy focuses around the intersections of chronic pain, mental illness, and opioid use. So welcome to all of our panelists, and thank you all so much for joining us today. Now we're going to watch the Beyond Stigma video, so please feel free to add any questions or comments that come up in the Q&A box for later in the webinar. If you have any difficulty seeing the video over Zoom, we'll also share the link in the chat if you would prefer to watch it in a separate window.
Let's do a thought experiment. Imagine you're living with opioid use disorder, also known as opioid addiction. This condition can affect anyone and can have devastating consequences. But you've sought help. Methadone is one part of your treatment. With the help of this medication, support, and a lot of hard work, you've had a more stable life for almost 2 years. But you're still stuck with the stigma. This creates major challenges, including when you need treatment for acute pain. Now, imagine you've fractured your arm. You're treated in the ER, but you're in a lot of pain, so the doctor says they can prescribe something to help. You know it's relevant, so you mention the methadone. Prescribing an opioid pain medication is routine for this injury, but now you get the sense they don't trust you.
You'll have to see your methadone provider.
You get 1 dose of pain medication, and you go home in pain and feeling rejected. You wish you'd never mentioned the methadone. At the methadone clinic, the doctor tells you they only handle methadone, and that you should see your primary care provider instead. You can't get an appointment with your primary care provider before next week, but you're in pain now. So you try a walk-in clinic. This time, you don't mention the methadone, and you're prescribed a short course of a low-dose opioid. At the drugstore, the pharmacist reviews your file.
Double doctoring, overdose risk, diversion.
They speak to you sternly about mixing medications.
Drug problem. No point.
You're discouraged, but hopeful your primary care provider can help. But before you can see them, you're asked to do a drug test.
Difficult.
Your primary care provider reluctantly gives you yet another short prescription for a low-dose opioid. They tell you it's actually your methadone provider who needs to handle this, and that maybe they should increase your dose. Now, exhausted by the runaround, frustrated by the way you've been made to feel, and overwhelmed by your ongoing pain, you feel you're out of options. So how do you cope? You resort to something you thought you'd left in your past. You contact a drug dealer. You know this might be dangerous for you, but it's convenient and available, and you trust your dealer. You finally get some pain relief, but now you're ashamed and fearful of losing all your progress.
Failure.
Now, let's imagine this scenario again, but this time, the providers you meet are aware of stigma, and systematic changes have been made to reduce its impact on the care you receive. When you mention you take methadone, instead of reacting with suspicion and discomfort, your providers ask you some important questions.
How long have you been taking methadone at this dose?
Instead of making quick assumptions, they see a more complex picture. They tell you your pain should be treated aggressively and with close follow-up. When did you last use other opioids? They understand you may require higher doses of opioids to effectively treat your pain. They explain that for some people with substance use disorders, the brain perceives pain differently.
How do you feel about treating your pain with an additional opioid?
Your providers know that just increasing the dose of your methadone is unlikely to be effective. How is this plan working for you? They understand that the distress of untreated acute pain increases the risk of returning to old coping strategies. Now that you're fully informed, you and your providers work out a treatment plan together. This plan is not simple, but with the support of your care team, your treatment is successful. The opioid pain medication is tapered off as your pain subsides, and you continue with your regular methadone dose. Imagine how you feel now. Stigma shames and discredits people with opioid use disorder and creates healthcare systems that dismiss and disconnect people from care. To change this, individuals must examine their biases, and systems rooted in stigma must be reformed. Only then can people with opioid use disorder get the compassionate, evidence-based care they deserve. We can move beyond stigma.
I will invite our panelists now to turn their videos on and we will begin our panel discussion. Thank you again, everybody, for joining us. I think just Kristen, if you want to turn your video on. So we'll start, we have some questions for the panelists and I will kind of start with one of you and then if everybody wants to join in, add anything on after, please feel free to. So I will start with you, Kirsten, if that's okay. And just to begin, can you share with us a little bit about why you developed this video and who the primary audience was that you had in mind when developing it?
Sure. Thanks, Kelsey. Well, I mean, maybe I'll start with who our intended audience was. We really hoped that this would be a video that would reach a very wide audience. So would speak to healthcare providers and people in the addictions field, as well as other parts of the healthcare system, and speak to people who are seeking out care and maybe living with opioid use themselves and may have experienced interactions like this with the healthcare system. We're also hoping that it's the kind of thing that may prompt discussion and some thinking about these kinds of interactions for a more general kind of public audience. Certainly, I think I was compelled to participate in the project because this is such a commonplace, routine experience for people. I think certainly as a healthcare provider, I can think of numerous instances of people telling me about interactions like this. I know that as a healthcare provider, certainly I think that we're managing a lot of competing demands. And I know that certainly decisions that I've made in the past probably have been experienced to some extent by people as not very helpful. The work on this project has really been illuminating for me. Allows me to think a lot about my work, and I've certainly learned a lot from the team and going through the process. So yeah, that was my inspiration for being involved.
Thank you so much. Do any of the other panelists want to add on to that answer? Yeah, Sean, go ahead.
I'd just like to add, yeah, I guess being a person who faced those similar situations that we're seeing in the video, sorry, lost my train of thought there. I've really benefited from a lot of doctors who not acted in that fashion, and I've been very much hurt by some who have. So I really saw the importance of the issue, and I'm just glad it's really had the reach that it has, and hopefully it's affected a lot of people the way it's affected me. People who use drugs, specifically opioids, don't really need any more stigma put on upon themselves, because stigma created by the individual is usually pretty powerful. So yeah, I'm just really happy that I was a part of this. I'm very proud to have been a part of it, and I hope it continues to get a lot more reach. So thank you.
Thank you so much, Sean. Abby or Kristen, did you want to add?
Personally, I became involved in this video really bit selfishly to learn more myself before prescribing, becoming part of like OAT. Yeah, I didn't know a lot, and probably brought more awareness to myself about probably some stigma I had myself upon some of the individuals being treated at the clinic, or just yeah, wording that was used. I'm still learning. Yeah, just again, it was just really interesting, and I've learned a lot and continuing to learn a lot from this project for sure. Yeah.
My motivation, this video is created as part of a larger project trying to improve the care of people who use drugs, specifically opioids in primary care settings, using education. And everywhere we turned in thinking about what should an education program look like, how do we need to adapt existing education programs, why do we need education programs for this therapeutic area in the first place, it kept coming back to stigma. Why it's very well recognized that, for example, in medicine, medical education, undergraduate medical education, when people are learning to become physicians, there's very little education around care of people who use opioids, treatment of opioid use disorder. And when you dig into that, it's very much driven by stigma around substance use. Why do we regulate substances like buprenorphine or methadone in particular ways differently than we regulate opioid analgesics like morphine or hydromorphone? And when you dig into it, obviously there are multiple reasons, but stigma has a really important role to play. So we didn't feel like we could effectively go forward with an education program that did not address stigma. And we're also looking for ways to build those bridges between people who use substances and healthcare providers, whether it's family physicians, nurse practitioners, pharmacists, who maybe don't come in contact together very much or enough for talking about issues of substance use. And so if we could create a video that all those different parties, like Kirsten was saying, could sort of, it could appeal to them, and you can sort of hear that from what Kristen is saying, what Sean is saying, that it's sort of appealing to all those different kind of people. Maybe you could create a bit of a platform through which, even outside of clinical care, people who use substances and healthcare providers could sort of come together on the same kind of page.
Thank you so much. Yeah, I think you've all touched on why it's so important to have this conversation, and why this video really needed to be made. Would anyone like to kind of elaborate a bit more on how the video was developed?
Go ahead, Kirsten.
Oh, no, go ahead, Abby. I was just going to also say, I think just on reflecting, I'm still answering the last question, I'm sorry, on reflecting on, the process of figuring out like the kind of care that I want to be able to provide to people. Like, I did spend some time several years ago now working in kind of that standard kind of methadone clinic environment. And it was horrifying for me. Like I felt like a horrible healthcare provider, and I left there not really, I mean, for all sorts of reasons. I could see it wasn't working for people. I didn't like it. It wasn't a way to engage with people. But I left there not with a really good understanding of you know, what was really underneath all of that and what was at play there. And I mean, the process of developing the video has really and all of the work surrounding it has helped clarify that. Maybe Abby, I'll let you answer kind of the process for developing the video.
Well, I think the most important part of the process, because we did aim right from the beginning, which we've done with other tools that we've created, to engage all the stakeholders or target audiences that we wanted the video to reach. So we didn't think we could create a good video that didn't involve people who use substances, that didn't involve pharmacists, nurse practitioners, physicians in primary care settings, et cetera, et cetera. So that was, I think, probably the most important part about the video development, was creating a collaborative environment with input from multiple perspectives, doing my best to sort of try and flatten hierarchies and sort of create a space in which everybody could have equal input into what the into what the video could look like. And I think the good thing is that all the people involved sort of did have a previous working relationship and involvement in different aspects of improving opioid use disorder or substance use care. And so it was quite amazing to watch actually how around different ideas the script for the video came together. Obviously, a really important part of it was engaging a great animator. Shout out to Lily Fang, who has created a number of great videos besides this one for other important issues, and very helpful in sort of turning our thinking and script into something that could actually pop out on a screen in the way that it has.
Thank you so much. Sean or Kristen, did you want to add on anything about the development? Yeah, Sean, go ahead.
I'm just really happily surprised how well it all came together. As Abby so well put, it was people from all this disparate backgrounds. But once we really started talking about the issues, it was really amazing how much we had in common as opposed to not having in common. I didn't really see the project forming as well as it did, but I'm very happily glad that it didn't. I also like to give a shout out to other creators who aren't here with us today, and the creators of the animation itself. So as I said earlier, I'm extremely pleased with the final results of the video, and it was a really nice process. I think the teamwork, the trust in everybody upon the team was also very helpful, and yeah, we were able to pull it together, and I think we came up with a product that we all be very proud of.
Yeah, thank you so much. Kristen, did you want to add anything else on there?
No, I think everything was covered truly. Like, I feel so humbled to be part of this experience. And also to have work with someone with person with lived experience also added so much to this project. I felt like, and everybody, you guys, the rest of the panelists had so much experience with it, as opposed to myself just kind of getting involved with it and just being an outsider looking in. It was great. And everybody was just so, yeah, we involved. You just felt so welcome, and listen to it, like whenever we wanted to collaborate and just add anything else to like the video when it was being developed. Everybody was willing to listen, give input. It was just great. Very pleased with everything.
That's great to hear. Thank you so much. I'll move to the next question. So Sean, maybe you want to start with this one. What is really important, and this is of course a big question, but what's important to know about stigma in opioid use disorder specifically?
I think first and foremost is that it can be really innocuous a lot of the times. I know the stigma that really still resides with me is it could be a look, it could be just something that is said, it could be language, just really, really small innocuous things that people will say throughout the day. For example, I remember giving blood. A doctor requested a blood test for me, so I wanted to give one. And just the person, the assistant, the nurse, I guess it was, who was taking the blood, excuse me, was alarmed at my track marks on my arm from injecting drugs. And just the look she gave me and the comments she gave me, it hurts me to this day. I still, I'm really loath to wear t-shirts in the summer and everything like that. Yeah, so I guess the biggest thing was that, you know, you don't have to come out and necessarily say something like, you know, all drug users should be killed and shipped to North Bay, which has been said at actual overdose awareness event that we had a couple of years ago. But it's the smaller things that hurt the most, rather than ridiculous statements like that. Like I said, it could be a look, it could be someone using language. I guess an example of that would be clean. People use a lot of times the word clean when referring to your drug use or lack thereof, I guess one should say. Kind of basically inferring that when you are using drugs, that one would be quote unquote dirty. So I think we just need to be cognizant of the language we use, the looks we give people, and just, you know, put yourself in their position. No one ever wants to grow up to be someone who injects drugs, but sometimes, you know, life happens and people deal with traumas and whatnot in different ways. And, you know, when they get the support and help they need, they can really, you know, start to be happy and healthy members of the community and, you know, start to give back a little bit. I'm just lucky, very, very lucky, especially in this overdose crisis, to be one of those people.
Thank you so much. And we really appreciate you sharing your personal experiences with that as well. Do any of the other panelists want to add anything onto that answer about kind of what's important to know about stigma?
I mean, I just want to echo Sean's point about the, you know, there's the very obvious instances of stigma that's often playing out at the interpersonal level, like a healthcare provider saying something really not helpful, discriminatory to a patient. But we were very conscious when we were developing the video that we wanted to, obviously, we need to, as a healthcare system, as healthcare providers, we need to engage with those things. Those are important. Those obvious kind of the interpersonal interaction. We need to engage with that, but we also need to account for the larger systemic instances of stigma, the less visible kind of stigma that's always happening, that always accompanies the way programs are developed, the way clinics are set up, the way people move around the healthcare system. We see the patient in the video, you know, going to multiple providers, working very hard to get care that they deserve to be receiving, and yet the system just cannot engage with them and cannot provide the care that they need. So we wanted to be able to represent that also. And I mean, that many thanks to Lily for helping us be able to do that. That was, it's hard for us to figure out how to do that, and she played a big part in that. I see somebody mentioned the creature that's always present there. Lily played a big part in helping us develop that image, and I think it's a very effective image.
Absolutely. Thank you so much. So to build on that, in the video, we see a lot of instances of stigma coming from the clinicians. So how can the clinician's stigma and a lack of knowledge affect the treatment that a patient receives?
Well, I'm happy to take a stab at it. Please, I'm interested to hear what others have to say also. I mean, this is the most obvious way in which stigma is playing out. And I mean, it's a lack of knowledge and attitudes and behaviors that are informed by larger societal beliefs about what it means to use certain substances. You know, where most of us are comfortable, say, with like the use of alcohol to a certain extent, not too much, but to a certain extent. But we're not comfortable with people who say choose to use opioids, to to do the same things that, say, alcohol does, like provide pleasure and provide relief. And we're even as healthcare providers very informed by these like pervasive societal ideas about what it means to use certain substances, what it means to have an addiction, like these like long held ideas about, you know, it being a character flaw and a loss of or a lack of self-control, you know, a lack of willpower. So, I mean, it's those kind of very pervasive, strong held beliefs about things like substance use and addiction that inform people's behavior at the interpersonal level. People are obviously acting on the idea that, you know, somebody ought to be behaving differently. They ought to have made different choices for themselves. And it's kind of like their fault that they're here in this situation requiring help. So that's how that's playing out between healthcare providers and patients.
Thank you so much. Do any of the other panelists want to add on to that? Abby, yeah.
Yeah, sure, I can add on to that. I mean, you know, it's specific, like going back specifically to the video, I mean, could we imagine a situation, could we put ourselves in the shoes of the patient? Imagine breaking your arm and not being provided pain control, any means to control your pain. You know, this video is not based on a specific person's experience, but is very much reflective of lived experience of people who use drugs in hospital settings, in emergency settings, and other settings. How can we accept that for anyone? We wouldn't accept it for the vast majority, and as healthcare providers, we would not accept that kind of treatment for the vast majority of people. How can we accept it for a specific group of people who use substances? And I think that sort of positioning, that's what we struggled with in creating this video, is, as Kirsten is saying, the point of identifying stigma is not about blaming individual healthcare providers necessarily. There's certainly in all instances in other therapeutic areas bad behaviors which certainly need to be addressed, but that's not what we're really trying to identify here. Even when a healthcare provider may be well-intentioned and probably is well-intentioned in this case, there's a concern around providing opioid analgesics that may end up harming the patient if they use them inappropriately. That's, you know, so the positionality of the healthcare provider is, what can I do that I think is in the best interest of the patient? But in many cases, because of stigma, that kind of positionality is poorly informed. And also the idea, for example, you saw in the video, we include this thing of, oh, well, maybe you should get your methadone. You should increase your methadone as a way to treat your pain. And again, that relates to misunderstandings of the role of methadone for treating opioid use disorder versus as an analgesic. And if we were better educated as healthcare professionals around appropriate treatment for people who use drugs and for people who are on methadone or buprenorphine or other opioid agonist therapies, we would act differently. We would not probably recommend just going to a methadone provider to increase our dose of methadone as a way to treat acute pain. And so, you know, really disentangling the intentions of the healthcare providers from the actions that happen within the health system, I think is really important part of identifying. And it's not easy to do. We struggled with it in the video. We hope we've sort of in some ways disentangled it, but we really want to try and make that distinction between what the intention of a healthcare provider or other person who's in a position of power. There's a power differential, you know, and this can happen with hospital administrators and people who use drugs, security, major issues with security and people who use drugs and access to healthcare facilities, police, whenever there's that kind of power differential, how do we disentangle the intentions, which may be good in the people who hold more power, versus what the actual impacts are on the people who are seeking care and who need care.
Thank you so much. I think it's really clear that this is such a huge issue that involves so many different aspects. And I think you've all done a great job of including so many of those different perspectives in the video. So in the video, why is the urine drug screen problematic? And how could this have been communicated differently instead? Anybody would like to start there? Yeah, Sean. Oh.
I'll take a stab at it, I guess. Having provided many a urine drug screen, it's a really dehumanizing experience. You know, a lot of times, you know, sorry for my language, just literally whipping it out on camera in front of people that I've worked with, that I've known for a long period of time. And it really just, I didn't find that necessary. I also feel that the urine drug screen were very limited in their effectiveness. I know what I took. I didn't remind of that. I know there's importance of, these types of tests in regards to keeping people safe and everything. But I just think for having urine drug screens specifically for one type of medicine, i.e. buprenorphine or mostly methadone, to me was most stigmatizing of all. I see people leaving pharmacies with 200 morphine tablets, and they wouldn't have to go through the same process that I would, having to take a very small level of methadone. So ironically enough, since I stopped doing urine screens since the pandemic, been 2 years of virtual professional visits and whatnot that I've never done better on my methadone. I've got full carries. I have my dose split right now. I'm down to the lowest dose I've ever been. I haven't used in years now. And yeah, it was literally the lack of this, I guess we're looking for pervasive care that really kind of released the so-called liquid handcuffs and allowed me to realize my recovery to its fullest potential. So I think, at least personally speaking, not having to go through that was really helpful.
Thank you so much, Sean. Did anybody want to add on? Kirsten?
Congrats, Sean. That's a big deal. I think that our use of the urine drug screen scenario in this video was purposeful, and I think it's a perfect illustration of what Abby was just saying. This disentangling, or an attempt to disentangle intentions and like what the patient's experiencing and what what actually happens in the interaction between provider and patient. I don't know how obvious it is, but the urine drug screen in this scenario is handed out to the patient in the waiting room with no explanation about why it's being used, how it's going to be helpful for the provider, how it's going to be helpful for the patient. So the lack of privacy, lack of explanation, kind of this like, oh, well, you're the kind of patient who's going to need a urine drug screen, and everybody, you don't deserve privacy about that. Certainly, like I use urine drug screens in my practice, not universally. There has been this kind of practice prior, to kind of recent times, certainly inflicted by COVID, but also kind of leading up to COVID, there was a reevaluation going on about like just kind of this like across the board use of urine drug screens. I think we need to be constantly mindful about like every other test, like why are we using this? How is it going to be helpful in terms of like my own clinical decision making? How is it going to be helpful for the patient? And there needs to be a conversation with the person in private, like every other like conversation about tests that you're ordering, about why we're doing this, and people have the opportunity to ask questions about it and tell you how they feel about it, and there has to be a conversation about it. Yeah. So, and I mean, we've left it kind of ambiguous in this scenario, how helpful or not that urine drug screen is going to be in this kind of clinical scenario.
Thank you so much. Abby, did you want to go next?
I put my hand up and then I put it down because Kirsten said everything I was going to want to say, but then I put it up again because, again, and this doesn't show up exactly like Kirsten said, this doesn't show up in the video, but we do know that when we don't think about or reflect on how we're using this test, for whose benefit, in what way, even if it's not intended as such, urine drug screens can, for example, be weaponized against people who use drugs. So what? So you somebody's coming to you because they're seeking care for their pain, and you do urine drug screen and you identify that there's some other opioid that they've used in the last couple of days. And that can be used as a reason not to treat their pain. But we haven't addressed why the person is coming to us in the first place. They're coming to us because they're suffering. And we are using a test as a way to dismiss their suffering so that we don't have to deal with it, because we don't want to get entangled somehow in their care. And so there's a risk if we use these kinds of tests, or if we accept that these, these are the ways that things are done. And this is not necessarily at an individual practitioner level, right? There may be interpretations or, guidelines or practices by, for example, regulatory colleges, professional colleges, can be weaponized against healthcare providers, right? And so it's not necessarily just the individual healthcare provider decision-making to, make people who use drugs vulnerable. They are also entangled in a larger system where they can become vulnerable as well. But we have to be conscious and reflective of what the impacts of these kinds of decisions are, and why we are making them, sort of based on what imperatives for whose benefit. And we did include that in the video, but from all of our experiences as healthcare providers, as well as people who use drugs, we see these kind of routine, potentially, what can be characterized as routine clinical practices that can become weaponized.
Thank you so much, everyone, for all of your answers there. We'll go to the next question. Kristen, maybe you want to start with this one. But what does appropriate pain management look like beyond just prescriptions? And of course, if anybody else wants to add in, feel free.
I feel appropriate pain management is just sitting down and really listening to the patient, asking them questions. I know I'm still on the pain scale, 1 to 10, always go through that. Just listening, just what are they telling you? Because, just to think, would you rather live in a world where people trust you or not trust you? Just to feel like they're being heard, listened to, and then, just going from there. It's really hard to explain, but just, I know everything's time consuming now and rushed, and in clinics, it's just next, but it is important. And you do see the risk of, if you don't take that time to listen, where might that person go after your appointment, or, to further harm themselves, or just losing that trust, right? You want to just build that relationship so they will continue to come back to you and know that, you're just going to work best as you can with them to make them the most comfortable they can be. And also educating. It's not always, like you say, the medication side of things, just discussing physio, massage, acupuncture, just the different resources, even nutrition, exercise, all that stuff just has to be incorporated further discussing pain management.
Thank you so much. And I think that that's really depicted in the video from the first half to the second half, kind of what that difference of a healthcare provider listening to the patient can really make. So thank you. Does anyone want to add on to that? Abby?
I'll add on to that. I mean, one of the things we also tried to communicate was the sort of conundrum that people who are on agonist therapy face is, do they disclose or do they not disclose? Because if they disclose, then they potentially get stigmatized. If they don't disclose, then it's a double bind, right? Because then they are, lying, misrepresenting, and when somebody is presenting to healthcare, and I think certainly pain is one of the most common reasons that people present to healthcare. They're already suffering, then to have to go through the mental anguish of figuring out how do I present myself, and knowing that there are going to be consequences, but not knowing what the consequences are going to be of how to present oneself, would be an amazingly challenging situation. I'll share like a personal anecdote, because it's very, very small, but still created anguish for myself. And I can imagine, the repercussions were very small. If the stakes are much higher, how much harder it could be. So, I've had a couple emergency room visits due to pain, specifically seeking pain relief. And I learned over time, obviously I study opioids and things like that. I learned over time that morphine doesn't do anything for me. It must be the way my body metabolizes morphine. And I learned in consultation with a physician who's caring for me in the emergency department that I do much better with hydromorphone. So I learned that with one visit. Year and a half later, had another visit to the emergency room. And of course, routine practices to give morphine. And I had to think, well, do I tell this physician that, no, actually I do better on hydromorphone? What are they going to think about me? Are they going to think that I'm, quote unquote, drug seeking? In the end, the sort of the pain resolved. But that little, for somebody, who, potentially, who doesn't hold the same kind of potential stigmatization and vulnerability in an emergency room setting or acute care setting, that could get so much more amplified for somebody who wants to just communicate, openly that I have a history of using drugs. I've been helped by being on methadone. Please take that into account for my pain care. I think we would want to live in that world where people feel comfortable sharing that, but you can understand why the person in this case, in one situation disclosed, another situation didn't disclose, because of what they've experienced when they've tried to be open and disclose their history of drug use and treatment for drug use.
Thank you. I think that example is a really, really strong one to support your point there. Sean or Kirsten, did you want to add anything else to that question?
Just one thing, I just always really found it odd because whenever I would basically have, to resort to taking other painkillers and stuff like that, the certain doctors would reduce the painkillers that I was on, rather than, trying to find a middle ground, they would lower the amount of medication that I was on. And it was kind of like this cylindrical kind of mouse in a wheel almost type of thing where, I just wanted help, not to hurt. And I was finding my ways to do that. And unfortunately, certain doctors would punish me. And then it was just a matter of and build my levels up again to get to a place where it's again comfortable. Thank you.
I think the only thing I might add is that it's the overlap, kind of the dichotomy of the very clear overlap between not so much acute pain, but say like a chronic pain experience and what it like the factors that play into that experience and the factors that often contribute to a long-term substance use problem for somebody like Minnie. Those are often many of the same factors happening in a person's life. And yet for a long time, we've separated out pain care from addictions care. I mean, we've separated out addictions care from all other aspects of a person's care. There are very clear overlaps between a chronic pain experience and a problematic substance use experience for a person. We're starting to kind of bring those two together a little bit more, but we still see this kind of, a person experiencing pain, although we're seeing this change also, which also speaks to stigma, but a person experiencing pain, there's a credibility to that kind of experience. Whereas like say a person experiencing a substance use disorder, especially if they have pain on top of that, the pain is is discredited in that environment. And it's more, likely to be seen as somebody who's just looking for more drugs. You don't really have pain. You're just trying to get more drugs from me. I mean, it's a very like it's a sticky, complicated clinical scenario. I think it speaks to the way in which stigma informs the way care is provided, and we can see how that stigma, opioid related stigma, changes over time. Whereas previously it was okay to prescribe opioids to patients, and that was appropriate, compassionate care. And now we're more suspicious of people if they need opioids for their pain. I don't know. It's just it's interesting to me, and I think it all speaks to how pervasive stigma is, especially stigmatized ideas about how people use opioids.
Thank you so much. We have a few more questions here. I'll just invite any participants, if you have questions that come up, just to put those in the Q&A box, and we'll get to those in the last few minutes of the webinar. But our next question, this was touched on a little bit at the beginning, as well as I think in the Q&A box, but language is really important in this field. So what are some important things to keep in mind when we're speaking about opioid use? Sean, yeah, go ahead.
I'll take a real brief stab at it. I think having proper intent, like never purposely being offensive, is to me the most important thing. I never got offended by someone who is not, most modern in their language, or that they were willing to learn and still learning. So for me, it was always, just the intent. Someone who purposefully uses language that is stigmatizing or hateful, or anything like that, that to me is what really resides and really carried to this day. Language changes, it progresses, and as long as someone's making effort, I think most people that are in similar situations as I am are going to be very empathetic, and they're going to understand. As long as they see you making an effort, I think most people are going to really appreciate that effort. And just like a lot of things that our society does, language is growing and changing, and as we as individuals grow and change too.
Thank you so much. I think that's a really, really great distinction to make with the intent behind someone's words. Does anyone want to add on to that point about the importance of language?
I think language is very sticky, which is what helps make it so powerful, but also challenging. As was sort of in your disclaimer at the beginning, Kelsey, around opioid use disorder, right? I mean, it's a medical diagnostic label, but itself can be stigmatizing. Not all opioid use is problematic or disordered. The phrase itself, disorder, has a lot of implications which don't necessarily accurately reflect what people's opioid use looks like. And so I think it is important to be very careful about language, but at the same time, changing language itself is not sufficient to create the change that we want. It can be reflective, I think, of initiatives to reduce stigma, and is an important part of it, but is not sufficient. Changing a medical diagnostic label, going from opioid addiction to opioid use disorder, I don't know if has, significantly improved the lives of people who use opioids. And it's reflective, like Sean was saying, of sort of how language changes over time, and that we need to be sort of attuned to those, but I'm skeptical of how much sort of changing our language is going to be sufficient in the absence of other initiatives to improve the lives of people who use substances.
Thanks, Abby. Kirsten or Kristen, did you want to add anything on there about language?
I think just touching lightly, just to be cognizant of our own body language as well when we're speaking with our patients, because I know myself, you know, if you're in a rush and you're faced at your computer and they're speaking about their pain, and let's say they, you know, they were using opiates, like you might be just focused on this or filling out paperwork, not making eye contact, not really listening. So I think that kind of can push our patients away, or yeah, just to be cognizant of that as well.
Thank you. I think, oh, Kirsten, did you want to add on?
Well, I was just going to say, I mean, like we often, when you're thinking about language, we're often thinking about kind of, once again, interpersonal interactions, and mainly like clinicians with patients. But I was also struck by some stuff I was reading recently, just a reminder that language in the form of, say, like policy documents, stuff coming out in the media or from the government, is also really important. So, for example, you know, like the public and communities are far less likely to be in support of something called a safe injection site, and far more likely, I'm not sure what the degree of difference is, but more likely to be in support of something called an overdose prevention site. Like you know, Abby said, like language is powerful. It's not the solution to the problem, but to the extent that we can use it to the benefit of people who need access to services and are deserving of some help, you know, it's important that we're mindful of that, and that we encourage our politicians to consider the same.
Thank you so much, everyone. I think a lot of great points about the need to reduce stigma first and have our language follow, and not that that will be the answer to all of these sort of problems. Next question. So the end result in the video that we see is the person calling a drug dealer. Would you say that this is a realistic response to this situation? Sean? Go
Or I
ahead.
got to jump on this one for sure. Yeah, most definitely. You know, pain is pain, and people are going to, you know, try to deal with it as best as they can. Oftentimes, it's just easier to call someone, you know, down the street, especially in this epidemic that we're going through now, this fentanyl epidemic and whatnot. You know, that's literally cheaper than what people are paying for their prescriptions through the pharmacies and stuff like that. So, going through that type of illness, having gone through it myself, you know, I totally understand it. I just think we need a lot more support so that people don't need to resort to that. And a lot of times I almost get a little bit offended sometimes by the term drug dealers, because a lot of times people are just being seen by someone a friend who's going to help them alleviate that pain. You know, legally, I guess it could be called a drug dealer. But I would say most of the quote unquote drug dealing is just one person trying to help another because they've gone through a similar situation. And no one wants anybody to go through that, because withdrawal is it's horrible. It's really horrific. And, you know, people are going to do what they have to do.
Thank you so much, Sean. I think very succinctly put. Abby, did you want to add on to that?
Yeah, I was just going to add on to what Sean had said. Of we go, I think as humans, we go to where there are trusting relationships. And if you don't, I mean, healthcare is definitely built on trust. And if that trust is undermined, then we would all look to other people whom we trust. And there's even good scholarship on this about, you know, trusting relationships between people who use drugs and the people who supply drugs for the people who use them. And if there is a trusting relationship there, I certainly do think, and that's the feedback that we've gotten from people in similar situations, that is a realistic scenario.
Thank you. And I think one of Sean's points kind of segues well into this next question, but the COVID-19 pandemic has shown us the power and the importance of having a coordinated public health response to an epidemic. So how does that relate to our response to the opioid crisis? Big question. Abby, if you'd like to start.
I mean, I would argue that we have not had a coordinated response to the pandemic. As you know, I think our capacity for public health responses has been systemically undermined over years and decades. The drug poisoning epidemic should have shown us that. You know, SARS showed it to us. The drug poisoning epidemic should have shown it to us before the pandemic did. And again, I think it comes to at least one of the factors that people didn't identify the lack of a public health response to a major public health issue is because of stigma. Right? I mean, we know in some jurisdictions last year, there were more deaths from drug poisonings than there were from the COVID-19 pandemic. When we make comparisons of years of life lost due to drug poisoning versus COVID-19, very comparable. And again, in some jurisdictions, you know, more years of life lost due to drug poisoning than COVID-19. And of course, a lot of people have been working to try and mount public health responses to drug poisoning, but they have clearly not been sufficient. And it has been a struggle to get the drug poisoning epidemic onto public health agendas. Considering how long this crisis or epidemic has been affecting people in Canada. And you have to think that stigma is a major reason for that. And, you know, people, particularly people from the drug using community, keep asking, like, how many more people need to die before this comes squarely onto the Canadian public health agenda. You know, I don't think I have answers to that question, but the pandemic, I think, has shown us two things in comparison to the epidemic. One is that it's a challenge for our society to mount substantive public health responses, even to problems that affect all of society. And the second thing is the fact that we don't see the drug poisoning epidemic as something that affects all of society, when it has, for example, impacted life expectancy. Our national life expectancy for the first time didn't increase a couple of years ago due to the drug poisoning epidemic. The fact that we don't see the drug poisoning epidemic as a whole of society issue tells us a lot about how we see drug use versus, or substance use versus something like an infectious disease.
Thank you so much for that. Does anybody want to add on to that at all? Kirsten?
I mean, that was very well said. I don't have much else to add other than, you know, my own experience working in the shelter system here in Toronto throughout the pandemic. It is very clear, like we've seen to some extent COVID measures imposed on people who are homeless, despite the fact that COVID is nowhere near the top of list of priorities and safety concerns for people who are living in our shelter system and people who don't make it into the shelter system. And the drug crisis the opioid crisis has devastated people living in the shelters throughout the pandemic. And I mean, COVID has been there. It has caused problems. It has taken a few lives. It has caused illness, but nowhere near to the extent that opioids have killed people over the last 2 years. So that's all I have to say about that.
Thank you. Sean, did you want to add on?
Yeah, just to add on to that as a personal reflection, everybody that I used with 15 years ago is dead, basically. And I'm not trying to, over emphasize or make anybody feel bad or anything like that. I'm just stating a fact. Everybody who helped me to create Dual 10 years ago is gone. I basically lost all of my friends. I'm not going to talk about this too much. I'm going to start crying. And it's just too much. It's just too much, and I know everybody that I talk to, people who use drugs and whatnot, feel exactly the same way. We feel like we've really been abandoned by many levels of society, specifically media, the police, the medical system. COVID obviously is a very, very important issue, but so is this overdose crisis that we're facing right now. And yeah, we really feel that we've been abandoned. I think that's going to continue to lead to a lot more trauma and tragedy, unfortunately.
Thank you for sharing that with us, Sean. I think you've all touched on really the importance of, public health in addressing this crisis. And I would completely agree with Abby that it really has not been addressed at this point. We'll go to a question in the Q&A that connects a little bit to the kind of government role in a lot of this conversation. So we have a participant wondering about any policies, for example, federally, that would impact the healthcare sector or workers' beliefs, so kind of working to address stigma, or how certain substances are criminalized more than others, and wondering about policies that they can get behind or advocate for that could help with some of these issues. So anybody has any insight on that they would like to answer that one first?
I can speak to one very specific example as a jumping off point. So one of the sort of manifestations of stigma that people identified, so this was done through a national consultation, was the regulatory environment or the regulatory requirements for methadone prescribing. So previously, in order to prescribe methadone, it was required for healthcare providers to have an exemption from the Canadian Drugs and Substances Act to be able to prescribe methadone for the purposes of treating opioid use disorder. And in many ways, rightly, that was identified as a manifestation of stigma, and that perhaps addressing that or removing that exemption would help to improve care for people who use opioids. Now that exemption has been removed after consultation. This is a couple of years ago, but we haven't seen, it's not like we've seen skyrocket. It is specifically identified as a barrier because, for example, in primary care, not a lot of family physicians, nurse practitioners take on methadone prescribing, and so okay, the regulatory environment is too burdensome, and that's why people don't engage in methadone prescribing. And now we don't have that exemption. There are still regulations at provincial levels that may be barriers, but it's not like we've seen like a skyrocketing of healthcare providers taking on methadone prescribing. And so it's important to identify policies, but the policies really need to go like one-off kinds of things are, I use this as an example that one-off things are not going to be sufficient. We've got to look at the whole system and the whole culture of how we think about opioid use disorder and opioid agonist therapy. And it's going to take that entire, culture shift, I think, to see the change that we want. And of course, we can be strategic around identifying particular policies, but it's got to be really sort of a suite of policies. I think a lot of people, and maybe others want to speak to this, is one of those sort of high level issues that people have identified is the criminalization of drug use that touches on really every aspect and perhaps is at the root of things like stigma. And if we were to not criminalize substance use, that we would see that kind of structural and sort of sea change that is required. And I don't disagree with that. At the same time, we have to be very conscious about what does that process look like. People have looked to, for example, cannabis as a place for how other substances may be treated. But what we saw with cannabis was really not a decriminalization of cannabis, but or legalization was really a commercialization of cannabis, a very particular route through which the regulatory infrastructure for cannabis changed. And that has had very particular consequences and continues to impact harm, frankly, particular populations that are made vulnerable. And so the processes through which we change the regulatory structures for drug use, regulation of drugs, criminalization or not criminalization versus legalization versus commercialization of drugs needs to be done very thoughtfully. And we need to attend to whose interests are being prioritized. If we don't prioritize the interests of people who are using the substances, I think it's very unlikely that those policy changes are going to beneficially impact those people.
Thanks, Abby. Does anybody want to add on to that question or kind of that conversation, I guess?
I mean, I mean, in terms of like systemic changes, policy approaches, structural changes that I think need to happen, like we need within the healthcare system and within our larger supporting system, social services, housing supports, we need a more sophisticated understanding of what it is when we're talking about addiction and all of the factors that are often contributing to that experience for people. Sean, you said at the beginning, like people you don't grow up thinking I'm gonna be an intravenous drug user. Like there are often, not always, but there are often a series of things that happen in people's lives, things that preceded them and factors that have an enormous influence on people's childhood experiences and throughout their lives that contribute to a substance use disorder that, especially when we're talking about a substance use disorder that causes somebody to lose housing, to lose employment, to lose contact with their family, to be completely ostracized by society. And we need systems that are able to engage with the entirety of that experience. We can't just be doling out methadone over here and like sending out checks that don't really meet people's, needs for housing, let alone any of their other personal needs over here without ever connecting all of those systems. Like we need comprehensive, sophisticated approaches to addressing this problem for people within the healthcare system. We need a diversity of programs that meet people's needs. Like some people say, like we need programs for women who are homeless, who are mothers, who are using opioids. Like that's a very specific set of needs for people, and it's different from another group of people's needs around their substance use. And a one-size-fits-all approach it's just not, it's not working for people, and it's not going to produce the long-lasting changes that people deserve to have in their lives. So yeah, that's my thought on that.
Thank you, Kirsten. To kind of build on that question around, advocacy or things that people can do, are there some things that perhaps people that are on the call right now can do to help combat opioid use stigma in whatever field they're working in, whether that is healthcare or social services or any other specific field, if anybody wants to answer that one? Yeah, Sean.
I think just talking about it first and foremost is going to be the most important thing. I come from a pretty rigid militaristic background. My family has basically always been in the military, very, very conservative people. And I spent Christmas Day, my partner and I, with my sister, and a lot of members of said family was there, and they just asked the exact same question themselves, how they could health and how they can learn. And, it turned into a really lovely and really educational discussion about, what it is that's happening, how people are affected. So I think just talking to people, whether it's your families, people on the street, people that you work with, just keeping the dialogue and discourse open, I think is going to have the most substantial benefit. I know it has personally anyway.
Thanks, Sean. Abby, if you wanted to add on.
I did say specifically for healthcare providers, there's opportunities to normalize opioid use care in your specific setting. So you may not have gotten education around appropriate care for opioid use disorder. So seeking out that education, and especially primary care providers, you do have people who use substances, who use opioids in your practice. You may or may not know it, but you do. And asking people about their substance use, asking how you can support them around their substance use. Obviously, opioid agonist therapies like buprenorphine and methadone can be very helpful for a lot of people, but it's not the only way to care for people who use substances. There are a lot of other things that can be helpful and supportive for them. So really normalizing, just like, we wouldn't ever think about as a primary care provider that diabetes is not within my scope of practice, or hypertension is not within my scope of practice. And if we see that there are gaps in our knowledge in those areas, we seek out education and, from our colleagues, or formal education or reading, to make sure that we fill those gaps and make sure that we have the appropriate skills, knowledge, attitude, competencies to be able to care for those people who present with those conditions. And as healthcare providers, we can do the same thing for people who use substances. If you're a pharmacist, make sure you stock buprenorphine and methadone in your pharmacy. I mean, that's a major issue that people face, is and that's again a manifestation of stigma. Is people, they may be prescribed. So you may have, you go to your primary care provider and you're prescribed buprenorphine. Where are you going to get it is a major concern that people who are prescribed buprenorphine will face. Their local pharmacy who knows them many choose not to have buprenorphine available. Some do, obviously many do, but some don't. And so that's as a pharmacist, make sure that you have a regular supply and good practices in place for providing agonist therapies. And the list goes on. I think really sort of normalizing this part of care for healthcare providers is a very concrete and potentially very impactful thing that we can do to address stigma and improve the care of people who are living with substance use.
Thank you so much. I think this has been a really great conversation kind of about stigma in general and ways that we can move beyond it. To kind of bring it back to the video itself. So this video, as we said at the beginning, has been widely shared nationally and internationally, and it's been really well received. So what is kind of the next step from that video? Kirsten, if you want to start.
Sure, I'll start. I mean, so this video is specific to the experience of stigma related to opioid agonist therapy and somebody seeking treatment for acute pain. So obviously there are so many other aspects of opioid related stigma to explore. We're moving on to, we're currently working on another video more specifically related to the experience of Indigenous people and who are on opioid agonist therapy, which is very different topic within the larger topic of stigma, and has also been a really interesting process thus far. But clearly, like, this is the kind of thing where we could have an ongoing discussion for a long time. We're hoping we're going to have a series of videos that that come and that we're able to continue having conversations like this.
Great, thank you. Any other kind of comments on next steps?
So we
I'm
will
waiting
be,
for a call from Flores. Go ahead, Abby. My bad.
no, go ahead.
I was just going to make a bad joke. I'm just saying I'm waiting for an Oscar call for 2023. That's my next step.
You know, besides people individually watching the video, we encourage people to disseminate the video in their networks, whether that's professional or personal, for people to have a chance to watch and reflect. There are a lot of opportunities to sort of keep sort of spreading this message, and we will also be creating a discussion guide alongside the video, and that can help to support some of the same sort of discussions that we're having here today, to reflect further and think about, okay, we've identified that stigma relating to opioid use is at play in our professional practice or our workplace or otherwise. What are some ways that we can start to change that and address that at a local level? And then, you know, potentially this could also inspire change at a facility or regional level as well. So we will be sort of stay close to the subject matter website where the video is hosted. And I think it's also hosted on the SURE website from the CPHA. So there will be a discussion guide that will help to support some further conversations around the video as well.
Great, thank you. So our final question, and maybe we can kind of go around and each panelist can answer this one. If there's one thing that you want people to take away from this video, what would it be? Maybe Kirsten, we could start with you.
I think the most important thing people can do is just to step back and think about, think a little bit more carefully, a little bit more closely about what this experience means, how it speaks to you. If you're a healthcare provider, like, think about how you're operating interpersonally, but also how your clinic that you're working in is operating, what the effects of that might be on people, what are the things that you might be able to do to produce little changes. Yeah, so it's an opportunity just to think a little bit more carefully about things.
Thank you. Sean, would you like to go next?
Yeah, I'd say, and this project is a great example of that, is to be equitably inclusive. From the very start of this project, people who use drugs were involved in an equitable way, a way that made us feel like a meaningful part of this project. And I would just, if there's anything I would ask people to take from that, is just to, when they're doing an initiative or project or anything that's going to serve the needs that people use drugs, you need to include said people who use drugs in an equitable fashion. There's a lot of times people will invite someone who uses drugs on a project at the very end. We kind of call it the 90% rule at people that advocate for people who use drugs. And I just think, yeah, including them in that way that affects them so much is what's going to help those people the most, including myself. So, sorry.
Thank you. Kristen, would you like to go?
Sure. I think it's just an opportunity to self-reflect, self-identify, actually, some personal stigmas that we may have carried and learn ways to change those. Way to better empathize with our patients. I'm talking from a healthcare professional side of things. I always understand that there's a bigger picture than what we are seeing in our offices. There's more going on. We don't know what's going on in the family, their own environments. It's just a way to learn and offer different ways to show respect and it's just, there's so much I obtained from being part of this video for sure, and excited for the ones that are coming up.
Thank you. And last but not least, Abby, if you'd like to share.
So one thing that I've learned from Sean over time, you know, as it relates to the video and some of the other work that we're doing, is that small actions can have very big impacts. And that goes both ways. So actions that sort of reinforce or perpetuate stigma can have long-standing effects and consequences. But the flip side is that sort of conscious provision of care, person-centered provision of care, can have long-lasting beneficial impacts. One of the things that Sean put in the chat was, it was a doctor who listened that really changed his life and maybe saved his life. Very well has saved his life. And so, some of these issues may seem really big, but that doesn't mean that small actions can't have a very big impact. So I would say that's, for me, and I hope for others, maybe that's an important takeaway from this video.
Thank you so much. So that concludes our panel discussion today. Share here. So we are out of time, but we really appreciate everybody's interest in this topic and want to again thank all of our panelists so much for sharing all of your wonderful insight with us today. We'd greatly appreciate any feedback that participants have on today's webinar and invite you to complete a short survey that will appear when the call ends. And additionally, you can send any comments, questions that you might have to us at substanceuse@cpha.ca. The webinar has been recorded today and it'll be posted to CPHA's YouTube channel, as well as the Canadian Substance Use Resource and Knowledge Exchange Center at substanceuse.ca. We will also send out the link to the recording to everybody who registered. So please stay tuned in the CPHA weekly update or the SURE newsletter for information on future webinars, and keep an eye on the Subject Matter Health Research Lab for those upcoming resources that we discussed today. So thank you again, everyone, for joining us today, and we hope to see you soon.